Mammographic surveillance in early breast cancer patients aged 50 years or over, results from a Mammo 50 non-inferiority trial of annual versus less frequent mammography.
So I'd like to thank the organisers for their interest, for inviting me to this press release and their interest in our study. So I'm presenting this today on behalf of all the co-investigators listed there. Apart from the funding of the study, which was funded by the UK National Institute for Health Research, government funding Health Technology Assessment Programme, I have nothing to declare. So the background to the study: current guidelines in the USA and Europe recommend annual surveillance mammograms for an unspecified period after treatment for early breast cancer. Within the UK, our guidelines recommend annual surveillance mammograms up to 5 years and then revert to our 3-yearly screening without specified risk stratification. We know that annual mammograms are a burden not only to the system, the healthcare system, but it also causes anxiety to patients. And this study was commissioned by the UK government because further evidence was needed to determine the optimum frequency and duration of mammographic surveillance. So this was a study. Women aged 50 years or over at diagnosis who'd undergone previous treatment with curative intent for invasive and non-invasive breast cancer, and they had to be 3 years post-curative surgery. At 3 years, they were given a baseline mammogram. Everything had to be clear, and then they could be randomised to annual mammograms or less frequent. And the less frequent was 2 yearly if they'd undergone wide local excision surgery, or 3 yearly if they underwent mastectomy. So the primary outcome was breast cancer-specific survival and cost-effectiveness, with two of the many secondary outcomes of recurrence-free interval and overall survival. We had an embedded quality of life sub-study, and we allowed patients to consent and enter the sub-study if they wanted to, and 90% of all women agreed to be part of the sub-study. We didn't cap the numbers. So we used these 4 validated scales, and we collected patient quality of life data annually. So in order to power the study, we needed 5,000 women to detect a 3% absolute non-inferiority margin for the primary outcome, breast cancer-specific survival. This gave us an 85% power. The primary analysis, it was a pragmatic study, so the primary analysis is carried out on intention to treat, but there's a sensitivity analysis per protocol for the per protocol population as per non-inferiority trials. Oops. There. Thank you. So we managed to recruit 5,235 women into the study between April 14, September 18. And as you can see from the randomisation stratification, randomisation's balanced. So 44% of women were aged 60 to 70, 80% had wide local excision, 87% had invasive disease. So the study's reported now with a median follow-up of 5.7 years from randomisation, which, remember, that's 8.7 years post-curative surgery. And we've got 7% of women who have died, 116 of the breast cancer. 7% of women have an invasive breast cancer recurrence, 103 local regional, 102 new breast primaries, and half of the recurrences are distant recurrences, with 5% new non-breast malignancies. So what did we find? So I do have a blue line and a red line, and it's become purple. So we've demonstrated non-inferiority at the 3% margin, but also at the 1% margin. And you can see from the 116 breast cancer events, we've got 98.1% 5-year breast cancer-specific survival from randomisation, and compared to 98.3%, and the hazard ratio is 0.92. So we've demonstrated non-inferiority for the breast cancer-specific survival. And that's true for overall survival. And that's also true for relapse-free interval. So here we've demonstrated non-inferiority at the 2% margin. So the 5-year relapse-free interval rates from randomisation was 94.1 compared to 94.5, and the hazard ratio is 1. So having a look, so what happened within the study? We scheduled their mammogram and their mammograms, and we've got over 24,500 mammograms accounted for within the trial. It shouldn't surprise you that sort of nearly 16,000 of these are on the annual arm and just over 8,000 on the less frequent arm. Looking at compliance, we've got overall compliance of 76%. We've got more women on the annual arm complied compared to the less frequent arm. But the main reasons for compliance, again, shouldn't surprise you, that on the annual arm, there was more chance of missing a mammogram compared to the less frequent arm, there was more chance of having an additional mammogram. So we also looked at the 9% of women missing the mammograms, and we can report that only 35% missed these due to the COVID pandemic. So looking at those who truly complied with all the mammograms across all of the schedules, the 76%, that is our per protocol population. So we carried out the sensitivity analysis and the results remained the same. So the embedded quality of life, it's interesting to say that across all of the validated quality of life scales, there was no difference across treatment arm. And this is shown here across the years, across both arms. But there is this persistent, we really like the distress thermometer because it does measure sort of how patients are feeling. And there is a consistent 6 to 10% of patients that are registering high levels of distress across the treatment arms, across the years in both arms. Now, when we showed the results of the feasibility study to our Data and Safety Monitoring Committee, they recommended that if we're gathering these data in real time, to feed back to the clinical community that their patients are registering high levels of distress and to give the reasons for distress. So we got ethical approval and patient consent, and that's what we did throughout the whole duration of the study. And I just think quality of life is really important and was one of the key things that we did within the trial. But again, as I said, there's no difference between arms. So in conclusion, we would say that Mammography demonstrated that for patients aged 50 years or over and 3 years post-diagnosis having undergone curative surgery, less frequent mammograms are non-inferior to annual. But there has to be this caveat that there is a need to have a mechanism for easy access back into the system for both symptom management and patient support if needed. We think within the UK, certainly, Mammography provides evidence for changing clinical practice. Thank you.
Thank you, Dr. Dunn.